Could you each introduce yourself and maybe just give a little bit of an origin story about how you got to this space, why you care about this space, why we should listen to what you have to say?
So I'm Natalie Gukasyan. I'm a psychiatrist and an assistant professor at Columbia, like Julie said. And before that, I was at Hopkins, where I did my clinical training and stuck around for a research fellowship at the Psychedelic Center, where my work focused on clinical trials in folks with eating disorders, mood disorders, substance use disorders. I was appointed medical director at one point. I helped supervise our therapists and worked alongside some very cool, interesting people and learned a lot of fun stuff. And now I'm back home and trying to figure out what kind of fun stuff I can do back home. So listen to me. Thank you.
I'm Harriet de Wit. I'm at the University of Chicago. My degree is in experimental psychologist, so I'm a human behavioral pharmacologist, and I study effects of psychoactive drugs in healthy volunteers mainly, and under conditions where they don't know what they're getting. So my approach is very basic, laboratory-based, and I got interested in sort of psychedelic drugs maybe 10 or 15 years ago, in particular with MDMA, because MDMA shares a lot of pharmacology with amphetamines, and so I was interested in what's different about MDMA compared to other amphetamines. So I've then ventured out to do some studies with low doses of LSD as well. So I'm very much on the basic science side of things compared to many other people here, so I'll represent that.
Thank you. Tehseen?
Hi, everyone. So my name's Tehseen Noorani. I'm based at the University of Auckland, in Tamaki Makaurau, Auckland, in Aotearoa, New Zealand. I sort of got into this space doing the first substantial qualitative study, a retrospective study, which is at Hopkins in 2013. That began, which is on the smoking cessation pilot trial. And now I am the non-Indigenous project lead of a project called Community Strategizing About Psychedelic Therapy in Aotearoa. And maybe for the purposes of this, I've been running for a couple of years, convening a group called Reimagining Psychedelic Trials, a kind of interdisciplinary, very international working group.
Great. Well, you're on the right panel then, aren't you? That's great. Harriet, can you start us off, Dr. de Wit, and how do clinical trials differ from basic science and pharmacology trials, and where the goal is to isolate the effect of the drug itself? So what's the difference between basic science and clinical trials?
Good question. I think they're very different, and they're both very much needed. So I think that basic science studies are designed in such a way that you can identify a particular variable and look at a particular outcome and have a lot of control over whether that variable has an influence. Clinical trials, on the other hand, so for example, it might be looking at a receptor mechanism of a drug, or it might be looking at some behavioral component or some subject population that varies on some dimension that you can then exactly measure the outcome of that. Clinical trials, on the other hand, are looking at an entourage of different kinds of variables. You have different patient populations. People come in with different patient characteristics. You have different therapists, you have different therapeutic programs, number of sessions, and then the drug is, you're limited in what you can look at with the drug because it's so expensive and so large. So you have to commit yourself to a single dose, for example, or a single route of administration. And then the outcome measures also vary a lot depending on who your patient population are. So I see the clinical trials studies as being broad, sort of natural experiments in a way. And so we need the answer to all these different, each one of them is as well designed as it can possibly be, but we can draw our conclusions from all of them together. And each one has its own limitations, but we can draw some conclusions about how they all work together and what indications the drugs might work for example. Basic science can take a little piece and ask, well, does the drug affect an interpersonal connection, for example, or an interpersonal conversation? So you can take a very small piece of what you think is happening in the clinical trial and test it under laboratory conditions. You can give the drug under double-blind conditions so that people don't know what they're getting. You can bring in people with a very narrow set of symptoms, for example, some level of depression and no other symptoms, no other medications, no history of substance. So you can ask it in a very narrow population and then see under controlled conditions what it is that the drug does. And that will then inform, I think, the clinical trials. I think just aside from this, one of the things I'd like to see in the clinical trials, I see in a lot of the clinical trials, I see success. I'd like to see which clinical trials don't work. And only that way will we be able to discover what the drugs do. They cannot possibly do everything, and they cannot possibly benefit everybody. And so ultimately, we're going to have to see that it does work for this kind of population, doesn't work for that kind of, works for this, with this dosing regimen, doesn't work with that. And so we'll be waiting to hear about those negative studies as well. So just as a scientist, I'd like to see those negative outcomes as well.
Natalie, can you talk, this is kind of a broad question, but any sort of bullet points on like what are some of the main challenges or the shortcomings with the randomized controlled trials? Like what, you know, what can't the clinical trials do?
And also preface this by saying these are issues that are talked about all over the place in the field, and I'm sure all of you have heard this, right? Every paper has this section on limitations and says the randomized clinical trial has these weaknesses and these reasons to maybe to temper our interpretation of what goes on there. Broadly, though, it's hard with psychedelics that cause very profound subjective effects to blind people to the effects of these drugs, right? The randomized controlled trials, is that a chuckle or a cough? Well, maybe both. And so effectively, you know, are people actually being blinded? Are we really achieving the goal of the blinding process when we blind people in these studies by using a placebo or lower dose drug or some other non-psychotropic drug to compare the effects of psychedelics to? In terms of getting useful data about what to do clinically for folks, right? The procedures that we do in clinical trials are pretty highly structured. We want to be able to repeat the same thing for all sorts of people, but as a result, we're also limited in what we can do, and we don't have as much flexibility as we would in the clinic. So in many of the recent large multi-site studies, it's just a single dose of psilocybin, for example, which is probably not what people with severe treatment-resistant depression might need in total, right? People might need more doses than that. And in many cases, more psychotherapy than is built into the trials. So those are just a couple of limitations.
This idea of psychotherapy,
Yes.
what are sort of some of the less obvious problems that get posed by the way that psychotherapy is conducted in the clinical trials?
So psychotherapy is an interesting realm we could wander into, right? Because we have many, many decades of psychotherapy research that we could look at, and a lot of the problems that they ran into, we're running into now. A big issue that arose in a lot of psychotherapy studies was that of allegiance bias, where you know, are you surprised that the world expert on CBT found that CBT is more effective than some other therapy that they were trying to compare it to, right? Of course, like inevitably there will be some probably unconscious and conscious behaviors and things that people say as therapists in these studies that will impact the way that patients receive the treatment and how they respond to the treatment. So allegiance bias is a big one.
You know, I'm really tempted to ask, and this may be a little a little touchy. But there, you know, there was an article in the Times recently, sort of getting at allegiance bias from Roland Griffiths' research subjects. Are you comfortable talking about that at all? I mean, that's really an example of what you're talking about, perhaps. I know it's say whatever you're comfortable saying, sure. Including pass.
Yeah, this is a Times article, I think, called the Psychedelic Evangelists, that raised some questions about whether the practices at a place like the Hopkins Psychedelic Research Center were kosher and led to valid results in some of our trials. Very early on, some of the studies showed very high rates of people reporting very personally meaningful and spiritual experiences. And so I think the article just raised some questions about practices of people like Roland and others at the center and what they were saying to participants and how they might have been framing and having discussions with patients or folks coming through the center about what happened to them. You know, I think one other issue there is that the studies were designed to look for people who were interested in spiritual development. So it was a,
Right.
it was a study
So
of
it's
people who
already
were-
a bit biased, even in how it's like recruiting people to come be in the study.
Yeah. I think it also gets into this broader area of the cultural milieu that we're all in, right? We're all here, we're all interested and excited about this, and that inevitably bleeds into interpersonal interactions about this, right? When people who are, in many cases now, especially now that it's moved from healthy people to clinical populations, they come because they're having a problem and they're looking for help, basically, right? Even though you frame what's happening at the research center as research, right? The purpose of the research is not actually to treat people, it is to determine like an outcome, to answer a scientific question. That doesn't stop people from coming because they're suffering and because they're looking for access to a new and alternative treatment.
Do you think that these kind of promising initial findings are going to hold up over time? Do you think there's going to be replicability?
The short answer is probably once this is out in the wild, if this becomes widely used clinical intervention, the efficacy we'll see is going to be far less than what we've seen in some of the early smaller trials. That has happened for many interventions in psychiatry. So for SSRIs, for example, when there were no other drugs used to treat low mood, the clinical trials showed huge effects. And then now that the treatments have been available for decades, we see that the effect size is actually quite small. It's very puny. And so probably we're going to see something like that. And you could see the early signs of that in some of the larger studies where, for example, in the Goodwin New England Journal paper in 2023, where they studied a single dose of psilocybin for people with treatment-resistant depression, they saw some improvement, some significant improvement at 6 weeks, but not beyond that. And that was very different from what's been seen in some of the smaller trials where participants might have been a little healthier or less complicated. So I think we're sort of already starting to see the signs of.
Yeah, I feel like this is a really important point, that when you're dealing with clinical research, you're getting rid of every possible variable that's going to make things muddy, and you don't accept people into the study if they're going to make things muddy, and you really, you've got optimal patients that have been picked, and like a very serious protocol that you're strictly adhering to with a lot of prep and a lot of support, a lot of pre and post therapy and integration, and like out in the wild, there's just no way that people are going to be as sort of tightly monitored and supported. I know for the smoking cessation study, for instance, like, it's like after the dosing session and they're calling every day and having a lot of just a lot of support that you wouldn't typically get.
Yeah, I mean, the sorts of, as a function as a facilitator in some of these clinical trials, I'll say that the rapport and the closeness that you build in that scenario with a patient or someone you're treating in the trial is much closer and moves very quickly relative to what I've experienced in just my regular clinical practice. So I'll leave it at that.
Got it. Tehseen, thanks for being patient. Can you tell us a little bit more about this Reimagining Psychedelic Trials? It's a working group that you've convened. Who are you working with? What are you all up to?
Well, yeah, just beforehand, just to add on to that, if I may. Yeah, one of the things that I was thinking about when you were talking, Natalie, was about how hard it is to be specific about what we're even talking about with psychotherapy and psychological support, operationalizing these terms in a really clear way. I think it really spoke to the panel beforehand as well. But that seems kind of so important. And there's a nice article, Bill Brennan was the lead author from last year, where it was looking at the underreporting of the psychological support, psychotherapy parts of protocols in the literature. So there's a real issue around reporting that is central to trials, conducting trials. I mean, that's the end of it, right? You report it. The Reimagining Psychedelic Trials group it's been running for a couple of years. We have some eminent people on it, and some non-eminent people on it. And there's about 18 of us, I think.
Wow.
There might even be people in this room who should turn up more, but don't. And it's very international. It's sort of from Paris or Berlin through to Melbourne via the US. So it's a pain to find a time. And
Right.
we it's kind of a space for people from very different disciplines to just kind of geek out about methodological and epistemological questions around clinical trials. So about kind of how we know things about psychedelics through trials, and then how we know how we know things about psychedelics. And so we have pharmacologists, psychiatrists, biostatisticians, also cultural anthropologists, social anthropologists, placebo studies researcher, had a historian for a while. So it's a kind of nice, really interesting mix of folks. And yeah, for me, the imagining bit is really important. It's kind of trying to kind of break out of the boundaries of what a clinical, an RCT, for example, is, and think more broadly about what do we mean by trials, and how do we reconcile different kinds of knowledges around psychedelics, different kinds of systematic knowledges, which could even be kind of course, traditional knowledges around psychedelics. Or you could also think about trials in the legal sense. It's not something that we've done yet, but I think it's quite interesting because there's a whole mobilizing of like evidence through a legal system that is also around the terminology of trials.
I'm not sure I understand. What are you talking about with the legal system?
The legal system uses trials, right? You go to trial, you go to court.
Oh, the words.
Yeah.
Okay.
Yeah. So when you're testing something beyond reasonable doubt, there's a whole kind of procedure for establishing kind of truth.
Okay.
And so it's interesting to kind of put these things side by side. We've discussed things like placebo, unblinding, shamanistic practices, regulator requirements, lots of different things over the last couple of years,
I want to pivot. What can be learned about these sort of the surveys and like looking at real world data? And I think Harriet, I may want to ask you the same question, but talk a little bit about these surveys and just like looking at real world use outside of a clinical controlled environment.
Me?
Yeah, you, and then Harriet also.
Yeah. Well, I think it can be really interesting. It's cheap. I think it's good to think about kind of knowledge generation as a kind of economic matter as well. And in that sense, it's often really cheap to do. It's good for hypothesis generation in a lot of ways. It's even less controlled than clinical trials, which I know we've been speaking about as really controlled, and in theory they are, but in practice it's a massive kind of coordination effort of a lot of different variables, and I think it's a lot less controlled than it's often portrayed, which is part of the issue, including in the writing up of these things. So surveys are that much kind of further along, I think, in terms of kind of, the issues about them not being as controlled in terms of what one can infer.
I would second.
I want you to talk about the microdosing studies a little bit.
Okay, well, just to make a transition from this topic to microdosing.
Yeah.
I'm deeply skeptical of the survey studies that evaluate the effects of microdosing. They put out a question, do you microdose and do you benefit from it? And they get just unanimous positive responses. So, I mean, there's such a bias in the people that respond on those and that want to tell their story that it's just, you have to be skeptical of the quality of the data and the veracity of, how many people actually do it and what they benefit. And the other problem is that with microdosing, the benefits are so heterogeneous. You have, wisdom, antidepressant effects, postmenopausal effects. You have just everything under the sun, and better cognition and everything. So as a scientist, I have to say, it can't do all those things. And what exactly does it do? And from the point of view of designing studies, that is a real challenge, because we might do a small microdosing study, but we have to figure out what's the most sensitive outcome measure. And we don't know. We can measure the standard measures of how depressed are you, how anxious, how creative are you, is your cognition better? But we don't know what to measure, and we don't know exactly how the people benefit from it. The microdosing is an interesting example of a sort of a clinical trial that may circumvent the issue of placebo. So with the high doses of psychedelics, obviously people know when they get it. And the argument is that with microdoses, you're kind of below the threshold of detectability. So it may be possible to see beneficial effects of microdosing without having people be aware that they're getting the active drug, and then you can rule out the role of expectancies. Whether that can be done it's a real challenge. It turns out that the dose at which people detect any effects at all varies across individuals, so it's hard to come up with a dose that's just below the threshold of detectability. And then, of course, if you're too low, then you've got too low a dose, but someone's going to say, well, of course you didn't see any effect. So it's a very challenging thing. But in theory, you could give a dose that's just below threshold and then see if there are beneficial effects. And that's kind of what we're aiming at. The other thing we can do is see whether it affects these low doses affect brain function, even at a dose that doesn't produce any subjective experience. So it might be, so we've done some studies with EEG, for example, where we look at the brain's response to reward, and it's dampened a little bit at these very low doses of LSD. So that's one possible way that we could go at looking at the effects of microdosing. I've said I'm for basic science, and when I say basic science, I really also want to include human-controlled laboratory studies. So I think that's a really important part in the psychedelic field for sure, because it's very difficult to study psychedelic drug effects or what we think of as hallucinogenic effects in animals. So I think we really need human experimental models for a lot of what we do. So I'm not sure I answered your question. You said, what about microdosing? It's an interesting field and a challenging area of research.
Yeah, I mean, it's like we don't have the tools to properly measure. If there are little effects, it may just be that our tools aren't good enough to measure those little
exactly.
effects.
You never know that they aren't sensitive enough. I just have to put in a plug for a recent finding where we looked at a low dose of LSD in people who had symptoms of depression. And it looked like the drug had a different effect in the control subjects compared to in the depressed subjects. And I thought that was kind of an important piece, because it suggests that there's something different about the brain in those even mildly depressed people that makes them respond differently to the drug. So that's the kind of thing that we can do in our human laboratory studies that I think are needed to just to understand what the mechanisms are. So
yes.
I'll stop. Sorry.
I may ask all of you this, but I'm going to start with you, Natalie. What are some common disconnects that you see between study findings and what the true evidence is versus how they're reported in the media or how they're portrayed in popular culture?
Probably one issue is that a lot of very itty-bitty studies get a huge amount of media attention. So there's a little bit of a formula, right, where there's like the experimental finding multiplied by the number of times it's mentioned in the press, and that actually results in what the culture around us absorbs about the findings and how much importance we put on them, right? So I think for a lot of the earlier studies, there was a lot of excitement about what was actually a group of pretty small studies that otherwise would not have garnered so much attention or importance laid upon them. And the other thing is, I think the lack of emphasis on psychotherapy could be a big issue. I know that was a big focus of the panel right before us. I think there's a lot to say about that and what psychotherapy is, how is it defined, does psychotherapeutic or what do they call it, psychological support, does that count as psychotherapy? I would argue yes, it does. So I think there's an underemphasis on the container that is built around the psychedelic experience in a lot of these trials, which involves a huge amount of support, probably more support than is likely to happen out in the wild if these treatments are approved.
Harriet, what do you think the media sort of misses when they're covering psychedelic research?
I think the media is set up to make something of the most sensational findings they can find. That's how they're designed. So they're not going to look at the best controlled studies or the studies that don't show an effect. That might be a really important outcome, for example. And they're going to look for something that's really exciting to people. And so then they just exaggerate in a sense.
That is a really good point, that if a study comes out and says, you know, we looked and we couldn't find anything, or we looked for a difference and we didn't see a difference, that doesn't get a lot of press.
Not at all, not at all.
And these null findings are really important to basic science and clinical science. And sometimes the journals don't print or accept studies where people say, well, we didn't actually find anything. You know,
yeah, it's a real issue. I know some journals now approve the protocol. They'll publish the protocol, and then later you publish the findings. So the problem with what we call negative findings, is that the study could have been designed poorly, and then there could. And You can criticize any study afterwards for they didn't do this and they didn't do that, but at least by approving, reviewing the protocol first ahead of time, then the negative findings might have a little bit more weight.
Yeah, the problem now with people getting published saying we're going to look at this is that other people read it as if it's already done and it's a done deal and there's something there. I mean,
Yeah, you look for the results section. Where are the
sometimes,
results?
I think sometimes groups publish because they just want to say, we got here first, we're thinking of this, we're going to do this, you know, watch us.
Yeah, right. Yeah. You're right.
But
You're right.
it is a relatively new thing. It never used to
It is
be
a
the
new
case
thing,
that you
yeah.
would get published in a medical journal to say, we're going to do this study.
Yeah, right,
So that is a little concerning.
I think there's now also registries where you can register your protocol, and you won't get the nice publication on your CV, but it'll make the validity of the research a little
But at
stronger.
some level, it's good to get the feedback to make sure you've done it as well as you can. And so
Yeah.
you get some feedback saying, well, you know, somebody said you just exclude this group or use this outcome measure or something. So, because when it's all done, it costs so much money, and then if you missed out on something or did something wrong, then it's worthless.
Yeah, I think overall, I think there's a stronger argument for publishing or for getting your protocols out there than not. And one thing I would add in terms of media is it's kind of, I've noticed interestingly over the years, sometimes the reporter or the journalist will be really good and will be really nuanced, but then the headline will be written by someone else. You know?
Right.
So anticipating those kinds of dynamics can be tricky. And then it's probably worth also mentioning the interesting recursivity between the way in which studies that can be done and then they're reported in the media, but then that affecting the expectations of people who come into future studies. So it's kind of, that's kind of an interestingly complicating kind of factor, especially with substances that are very sensitive to the mindset of people using them.
Yeah, it is like a sort of a vicious cycle or a virtuous cycle, depending on which way it goes. But that's a really good point. Okay, sorry, but we need to talk about placebo. And I know we're all tired of talking about placebo, but I do think it's important to just sort of, you know, what is your opinion? Can you effectively, functionally, really blind? Natalie, you were there. So
I was there, yes.
Well, was there ever really a big mystery of whether somebody was on placebo or psilocybin?
Usually not. There have been cases, I think, where people were surprised. But it's often quite obvious in the studies where they have measured it. The rates of people guessing correctly what treatment arm they were allocated to is over 90% by both participants and study staff. So it's quite substantial. It would have been nice if some of the larger multi-site studies also measured that and asked people what treatment arm they thought they were allocated to. For example, it could have given us information from the Goodwin New England Journal trial that tested 1 versus 10 versus 25 milligrams. If 10 milligrams, which actually wasn't a potent antidepressant, if that was distinguishable by participants between the 10 and the 25. So maybe a lower dose could function as actually an adequate placebo dose. But people just aren't measuring this, and I can imagine why pharma companies are not incentivized to measure whether people believed that the blinding that the study involved was actually effective. And the question, you should probably also go back to why we blind in the first place, right? We blind because we're trying to figure out the difference between, we're trying to figure out the contribution of the drug or intervention itself over just being involved in a trial being measured, right? So people over time will just get spontaneously better, and also people who are being observed will get spontaneously better. People who are interacted with in a nice, warm way will get spontaneously better. I recall being in an investigator meeting for a study, I won't say which study, and we had a presentation by somebody who was an expert in placebo effects come and say to us, this long presentation, he gave this long talk about all of the factors that will enhance or inflate placebo effects. And they included things like a nice, warm presence, someone who takes the time to get to know you, maybe touches you a little bit, not too much, asks you really personal, deep questions, really takes the time to understand you. Right. And they're and those
You're
are the
doing
things
all of
you
that.
should
It's check, check, check.
And that is part and parcel of the intervention we're talking about. I don't think it's extricable, and for that reason, I don't think saying that someone is just getting psychological support, it's not psychotherapy, is enough to distinguish it from actual psychotherapy. Because once you have a person who's suffering, enter a room with someone who has a lot more power than them in an institution that has all these accolades and is known to be a place where big, interesting things happen, I don't think you can divorce that from the psychotherapeutic relationship that occurs in other settings. So whether everybody needs that level of support, like the in-depth, many hours of psychotherapy, I think is another question. That's an empirical question, and it would be great to design some studies to answer that, to provide, randomize people to minimal support or more advanced support, offer them the opportunity to opt into more support if they feel like they need it, or if the investigators seem concerned about the person. But it's a huge question. It's going to be maybe the most important question as we think about implementation, right? So I think we have a lot to figure out.
Harriet, do you want to say anything about placebo? I know you maybe feel like you've discussed it enough and that we shouldn't have to bother at this point.
Yeah,
but
it's really,
any words of wisdom about this issue?
I don't have any wisdom on the issue. It's an intractable sort of challenge, as is the combination of drug and psychotherapy. The two somehow work together in a way that we don't know. So it's a similar challenge and how expectancies of getting beneficial effects can influence the outcome. People have tried, the previous speaker used niacin, I think, and they try methylphenidate in some cases. So I think more like that with active control drugs would be helpful.
Tehseen, I'm assuming placebo issues are discussed in your group. What's the consensus?
Ooh, I don't know if I can tell you that.
What are some opinions if there's no consensus?
The dissensus. Well, there's been some, I think there's been some conversation that is supportive of this kind of multiple dosing, different levels of dosing from low to high. I mean, in terms of placebos, in terms of unblinding and people realizing, I think often I find that conversation is too limited to kind of therefore activation of expectancy effects or something. On the one hand, you can say, does it matter? And I think the reason why it matters is not because the treatments aren't working, but it's because a treatment that may work next year may not really work in 10 years' time when the hype and the expectancies and kind of culturally are kind of very different around psychedelics, if psychedelics are somewhat more normalized. So that's something to bear in mind, but we don't tend to think in that way when with the findings that then go through to regulators. There's this sort of idea of like, this intervention works for this indication, punto, and not like at this time in this context and so on. So there's sort of some added variability there. And the other aspect of it that I think is interesting to think about is to kind of follow, if you follow the participant story, their own narrative through the trials, and what are people doing for these like 2 months or whatever that they're in a trial, they've been unblinded. Are they really doing exactly the same thing as the participants who are in a placebo condition, or are their behaviors kind of changing as a result? So that adds a whole load of other kind of complications. We spoke about them as dark loops in trial design that aren't reported on, that aren't measured, that are kind of essentially ignored.
Dark loops.
Dark loops.
I like that. It's a good name for a band.
Can I add one more point?
I want to ask you, Natalie, a question, but go ahead.
Well,
Maybe
just
you're
the
answering.
other side of placebo effects is nocebo effects, right?
Yeah.
I think that's what you're
Can
getting
you
at.
explain nocebo to anyone here who might not know what that is?
So nocebo is when somebody maybe negative effects that can happen if a person believes that they've received a non-active treatment in a study. So if they believe they received placebo over psilocybin, for example. And so that itself can result in demoralization, feeling worse. I could tell you I've had a conversation, more than once I've been in a session with a person who believed that they received a placebo, was devastated, and I spent the entire hour managing their disappointment and demoralization. That is not what I'm doing with someone who received probably psilocybin afterward, right? So it's a totally different approach.
Well,
and
it's worth mentioning, actually, that it's potentially dangerous for people who are in a study and they're trying to get something that they think is the only thing that's going to help them, and then they realize they've gotten placebo. And the truth is that there have been some situations where people getting suicidal, not from the drug session, but from the fact that they received placebo. So it is a big deal still. It's very hard to functionally unblind. I don't know how you unblind if you're looking at like Ibogaine or something, what are you going to give? You can't give niacin that's like extended release over, 20 or 30 hours. So, there are sometimes you just cannot blind. But are there certain patient populations that you think should be unblinded. I know we talked a little bit about schizophrenia. There is a schizophrenia trial being planned where it's not going to be placebo-controlled because this is potentially a group of people who are naturally at baseline maybe a little suspicious, and I think it's just not worth it to have these kind of button, who's got the button sort of games. And I think it makes sense sometimes that you just run everybody through the study once on placebo, and you run everybody again on the study drug. And this is one case, I think, where it may be okay. And I imagine there are other cases. Do you have an opinion about, like, there's maybe special study design features for patients with serious mental illness that may be different from what we've been doing?
It's a tough question, I think, but as you say, like a crossover design where if you did receive placebo, you do later have the opportunity to get the active study drug can help mitigate some of those things. But then again, that leaves a person waiting and hanging with an untreated condition, right? We often taper people off of their medications and remove them from their other treatment that they're getting. And so is that ethically right that we
Right, that's even more complicated. Like you've had somebody come off their medicines in order to go through the study and now they're getting placebo. So they didn't get the study drug and they're off their meds. And that's a particularly vulnerable place for some people to be in.
Yeah, so I don't know that there's a specific group of people who we should, treat a little bit differently for that reason, maybe with the exception of folks who might have delusions or paranoia. But then the question is, are we achieving the goal we set out to achieve if we don't have sort of a placebo, or if we do have a placebo group, right? Is it that are we actually getting the data we hope to get by doing that?
I think if you have a small pilot study and you're just looking for safety and not efficacy, and you say, this is an unblinded study. I mean, there are certainly unblinded pilot studies that kind of get a pass.
Yeah.
I often wonder whether we could do more with the expectancies, with the instructions that we give to patients. And I don't know what the ethical limits on this are. But you could say, we're giving a drug that might benefit you, and then you might get randomly assigned to this other drug that might have some different symptoms, but it might also have beneficial effects. So there might be a way to control people's expectancies it's sort of in conflict with the therapeutic goals of making people better. There's sort of a conflict between doing research studies and benefiting the patients. But at some level, I think we can do something with instructions and telling people your control treatment is going to make you feel different, but there's evidence that it also improves depression or something like that. So I don't know how much the clinical trials tell people you're going to benefit. This is a drug that showed great promise for treating depression or something, and if you're contributing to it if you build them up to expect that there's going to be a good outcome. So I don't know what's ethical there or not.
Well, I guess in terms of ethics, I think comparative efficacy studies are better because it's like if you have cancer and you're trying a new chemotherapy, they don't either give you the new chemo or nothing. They give you the new chemo or last year's chemo that's also pretty good. And then you have a comparative efficacy study. So I think that's a way to get around the blinding is you're going to get something. You're not going to get nothing.
Right.
I think it's probably the most valuable kind of studies that we can ask for looking forward.
Comparative efficacy.
How does this actually stack up against treatment as usual, which is SSRIs or psychotherapy or both? Is it as feasible? Is it as acceptable to people?
Right.
Can they manage it with their schedules?
And it's also more ethical.
Yeah.
So I think that's sort of the next round of clinical studies. Will probably be more comparing apples to oranges instead of apples to placebos. We've run out of time, but there's more. Don't worry. We've got a couple more lectures today. Thank you. I think this one okay. Thank you.